Bismillahirrahmanirrahim. Today I am going to start with one of the most important topics, the topic of the diabetes mellitus. You all are familiar with that this disease is associated with a lot of morbidity and mortality. But before I start with the diabetes mellitus, its definition and its pathogenesis very briefly, I would like to go through the glucose and its metabolism. The glucose level, as you know, glucose is a basic source of energy for most of the organs of the body, especially the brain, which is a facultative glucose user. So it is tightly regulated in the plasma and it is kept from in a concentration from 3.5 to 8 millimoles or about 63 to 140 milligrams per deciliter. How is it controlled? The insulin plays a very vital, a pivotal role in the control of the glucose level. The main organ for glucose homeostasis in our body is the liver. The liver, when in the postprandial state, stores the glucose in the form of the glycogen. Further, it forms the glucose from the different other sources from a process known as gluconeogenesis, and so daily about 200 grams of glucose is produced in the body, of which 90% comes from the liver, that is the glycogen and the hepatic gluconeogenesis as I've already told you, and somewhat from the renal gluconeogenesis, which contributes a little to it. The glucose transportation and uses brain, as I've told you, is the main consumer of facultative, using about 1 milligram per kilogram per minute, that is equivalent to about 100 grams per day in a 70 kilogram adult. Glucose is transported in the cells through specific glucose transport units, which are called the glucose transport units. They are divided into about 4 types. The glucose transport unit type 1, most of the non-insulin mediated transport by many cells. For example, the cells of the cornea and others, they are dependent upon this. The transport of the glucose into the beta cells is through the glucose transport units 2. This is again non-insulin dependent, that it is not dependent upon the insulin. Similarly, the glucose transport unit 3, this is also non-insulin mediated, and this is in the brain. And glucose transport unit type 4, this is the insulin dependent, which is mainly the muscles and the adipose tissue. As you know that these are also the two major in fact organs in the way that they comprise much more as compared to the brain from their point of view of their muscle mass and the mass of the adipose tissue. Why I'm going to tell you this and I'm telling this all is that the disturbance in these units, glucose transport units, or their improper formation can lead to a sort of insulin resistance. The insulin, which is a main hormone which controls the sugar level or the glucose level in the blood, is formed from the beta cells in a pulsatile manner. A rapid phase followed by a slower phase in response to elevated glucose level. The normal increase in the insulin secretion or insulin secretion occurs when the level of the glucose that exceeds to from about 70 milligram per deciliter, and onward this stimulation increases and it is secreted in the blood in co-molar concentration with the C peptide. This is a peptide which is secreted along with the insulin. After its secretion, most of the insulin, that is about 50%, is degraded in the liver. However, C peptide is degraded to a very small extent. This is a very important point because when we have to assess the actual level of the secretion of the insulin from the pancreas, we can assess it from the level of the C peptide in the blood. The other important stimuli from the insulin, these are the incretin effect, This includes the release of the insulin, decrease in the glucagon level, and delay gastric emptying. These are very important hormone-like peptides which are released from the gastrointestinal tract, and they have got a very important role in controlling the secretion of the insulin. The GIP, or the glucose dependent insulinotropic polypeptide, this is secreted by enteroendocrine K cells. The GLP-1, or the glucagon-like peptide 1, is secreted by the L cells from the distal ileum and the colon. And the inhibitors of these incretins, that is dipeptidyl peptidases, are there, which immediately degrade these different incretins. You can say this is based upon this. The DPP4 inhibitors are one of the most important class of drugs used in diabetes nowadays is synthesized. Here you can see this is in fact a schematic diagram to show you the effect of the different incretins. For example, the GLP-1 and GIP, they stimulate insulin release, inhibit glucagon release, and thus they lead to lowering of the blood glucose. Similarly, the DPP4, you can see here, these DPP4 inhibitors, they destroy, or they lead to the catabolism of these two hormones. So this is how we use the DPP4 like inhibitors. By using these, we can prolong the effect of GLP-1 and the GIP, so that we can get control of the level of glucose, in addition to the other drugs which are being used, for example the sulfonylureas, for example the metformins, etc. The mechanism of insulin secretions, as I told you, that insulin is secreted from the beta cells in a pulsatile manner. First there is a rapid increase in the secretion, and which is followed by a more protected phase. The insulin, which is very rapidly released from the beta cell, which is already performed or synthesized in the beta cells, and this is dependent upon the entry of the glucose into the cell. The moment the glucose enters these cells, this alters the metabolism. There is increased production of the ATP from the mitochondria, and this increased production raises the level of the energy, which blocks the channels which are responsible for the efflux of the potassium from this, and the potassium is stored remains in the cells, so it causes cellular depolarization, as we know everywhere else in the body. This cellular depolarization opens up the calcium channels, which lead to the net calcium influx, and both these components combined together, they cause the release of the insulin from the beta cells. And you can see here that those receptors, they can be affected by the sulfonylurea type of drugs which are used in the management of type 2 diabetes mellitus. The mechanism of insulin action in the body. Insulin is not only responsible for controlling the level of the glucose in the body, but it is also known as a mitogen hormone. It controls a lot of things in our body. For example, it can control the cell growth, proliferation, and the gene expression by the different cells, that is the mitogen activated protein kinase signaling pathway, and the phosphatidylinositol 3 kinase signaling pathway, that is responsible for the synthesis of the lipids, proteins, and the glycogen. Insulin does it by causing the you can say by sparing these different proteins and the lipids, so there's increased synthesis of that. Cell survival and proliferation is also dependent upon that, and plus the formation of the glucose transport unit 4, which is the main action of the insulin in our body. This is a slide which can sum up the different effects of the insulin in our body. The insulin, which is produced by the pancreas of islets of beta cells by the islets of Langerhans, which was identified by Paul Langerhans in 1869. You can see here the effect of the insulin upon the adipose tissue. Mainly it is the increased glucose uptake, increased lipogenesis, and decreased lipolysis. So thus, if there is a deficiency of the insulin, it would. Now coming towards the diabetes mellitus itself, this is a syndrome with distorted metabolism and inappropriate hyperglycemia due to either a deficiency of insulin secretion or to the combination of insulin resistance and inadequate insulin secretion to compensate, and results in abnormal metabolism of carbohydrates, proteins, and fat. Looking upon this deficiency, there may be either complete absence of insulin in case of, as we will see, or almost a major deficiency of insulin in case of type 1 diabetes mellitus, which is because of immune destruction of the islets of the islet of the Langerhans or the beta cells, or because of the comparative decrease in the insulin, comparative decrease from which I mean that whatever is required for, say, a person's weight, that much insulin is not secreted by the body, or there may be insulin resistance, that the insulin is being produced but the peripheral tissue, especially the muscles and the adipose tissue, they don't respond to its effect, so insulin doesn't go into these cells, and as a consequence the loss of the fat, the loss of the muscle mass is there, which is a characteristic feature of the diabetes mellitus, that despite appropriate appetite and intake of the food, the patient keeps on losing the weight. Incidence and prevalence, this has got a very high incidence and prevalence nowadays, especially in the past it used to be more in the affluent societies, but progressively it is rising in our areas, especially the Pakistan and India, Southeast Asia. That is about 346 million people worldwide, India and China being the largest contributors in the diabetes. In fact, diabetes is an epidemic form. It is increasing because of our normal daily life, which has become more sedentary, more intake of the proteins and more intake of the carbohydrates, and mortality is definitely higher in our countries, that is the underdeveloped countries, because of the lack of the proper diagnosis, in-time diagnosis, and medical intervention. How do we make a diagnosis? The normal range, as we said, it is about 70 to 120 milligrams per deciliter. This is regarding the fasting plasma level. The fasting plasma glucose level, if it is more than or equal to 126 milligrams per deciliter with the classical features, on one or two occasions we can label this patient as diabetic, though we do require a 2-hour post prandial level, which is if more than 200 milligrams per deciliter in a patient with classical hyperglycemic sign, that is the polyuria, polydipsia, and polyphagia. Polyuria means increase in the urinary output, polydipsia means increase in the thirst, and polyphagia means increase intake of the diet or meals. And a 2 hours postprandial glucose level of more than or equal to 200 milligram per deciliter during OGT. What is meant by OGTT? This is the oral glucose tolerance test, which is sometimes performed in patients in which we have got values which are not touching 126 in the fasting level and not touching 200. They lie in between somewhere. So we label it as glucose glucose intolerance. And how do we define it? HbA1c A1C level, this is again very important. This is the glycosylated hemoglobin. The level equal to or more than 6.5 is again indicator of diabetes. Impaired glucose tolerance, what I was talking about, that the patient is unable to tolerate the glucose. A fasting plasma glucose level between 100 and 125 milligrams per deciliter. That is not exactly crossing the limit of say 126 or 127, and it lies in between that. A 2 hour post uh, prandial glucose level between 140 and 190 milligrams per deciliter, and or a level of HbA1c between 5.7 and 6.4. This again comes in the impaired glucose tolerance. As many as one-fourth of the individuals with impaired glucose tolerance will develop overt diabetes mellitus within 5 years. So any person in whom we have a suspicion of this glucose intolerance, we should closely watch, rather guide the patient regarding his diet and the daily living style. Now, classification: the diabetes classically is been classified into type 1 and type 2. The type 1 in the past was used to be called as insulin dependent, and the type 2 was known as the non-insulin dependent diabetes mellitus. The type 1 usually presents in the earlier age, and among the type 1, about 90% of the cases they are immune mediated, and in 10% we may not have any evidence of autoimmunity. Some sort of polygenetic disturbance may be underlying that. Other variety of say type of autoimmune diabetes, the type 1 usually presents in the very young adults, and it may present at the age of 9, 10 or 11 years, while another form of the autoimmune diabetes, that is known as the LADA, that is latent autoimmune diabetes of the adult, that it has got the same pathogenesis but it presents at a later life, that is in the adults. And the type 2, that is because of the relative insulin deficiency and insulin resistance with beta cell dysfunction. This is one of the most commonest forms in the adults, and remember that it is characterized by two things, that is the deficiency and both insulin resistance and beta cell dysfunction is there. What is meant by beta cell dysfunction we will explain in a while. The insulin resistance, what is meant by it can take months or years to do so. Insulin resistance syndrome may be divided into type A, H here, and this is because of genetic mutations. This is again a sort of, you can say, diabetes mellitus. And type B syndromes, which is of autoimmune in origin. Why it is so called? The type A insulin resistance is usually found in the female, and it is because of some sort of genetic mutation, and it is characterized by hirsutism, acanthosis nigricans, a condition in which skin and body folds they become more in thickness and they may have a velvety appearance. And these, in addition to that, these ladies may have polycystic ovarian disease. Genetic defects in the beta cell function. This is moody, that is the maturity onset diabetes of the young. This is also known as the monogenic form as compared to the above two forms, in which the genetic pathogenesis is there. So to distinguish it from, they have labeled it as the moody or the maturity onset diabetes of the young, and that is because of the defect in the beta cell, and that is uh, divided into a number of lesions depending upon the gene involved. The Moody 2 and Moody 3 are the most common forms, primarily defect in the beta cell function without beta cell loss. So this is a form of beta cell dysfunction. This is divided into about four types: the mutation or alteration in the hepatocyte nuclear factor 4 alpha, that is responsible for Moody 1. The defect in the glucokinase, you must recall from your knowledge of biochemistry and physiology that the glucose is transported into the liver, combined with the molecule of phosphate, and that is with the help of glucokinase. The hepatocyte nuclear factor 1 alpha, which is responsible for the Moody 3, insulin promoter factor is responsible for the MUD4, and the HF and hepatocyte nuclear factor 1 beta is responsible for MUD5, and the neurogenic differentiation factor 1 is responsible for the MUD6. Remember one thing, that you not need to remember all these, but what you should remember is that there are two major forms of insulin, the type 1 and type 2. Along with that, those are the form of the primary diabetes mellitus. There are other causes, the secondary causes as well, but you should have a brief idea of what is being uh, there because or what is the change behind that. Genetic defects in insulin processing or the action type insulin resistance, the lipotrophic diabetes mellitus, the exocrine pancreatic defects, for example, the chronic pancreatitis, neoplasia, cystic fibrosis, hemochromatosis. We already talked about that when we talked about the liver. In case this is known as the bronze diabetes. The endocrinopathies, acromegaly, which is because of the excessive secretion from the anterior pituitary gland that is responsible for other features as well. Cushing syndrome, again because of the increase in the level of the adrenal hormones, the hyperthyroidism, the pheochromocytoma, and the gluconeuroma. They may be responsible for the increase in the glucose level in the blood, so they must all be investigated. And remember that the diagnosis of a disease doesn't depend upon the lab only, but it is also on the history and the physical examination. The infections, for example, cytomegalovirus, Coxsackie B, the different drugs, for example, the excessive use of glucocorticoids can lead to a thyroid hormone, interferon, which was once very commonly used for the management of the hepatitis C, and the thiazide, which may also lead to impaired glucose tolerance. And the diabetes may be associated with the genetic syndrome, for example, the Down syndrome, Turner syndrome, and the Klinefelter syndrome. Finally, diabetes and pregnancy, the pre-gestational or the overt diabetes, and the gestational diabetes. Pre-gestational or overt diabetes, what is meant by that? That a already known mother becomes pregnant, that is the pre-gestational, and the gestational is divided into type 1 and the type 2 again, and this is the impaired. And remember that in pregnancy there is almost some sort of impaired glucose tolerance. There is normally some sort of glycosuria, or increase the release of the glucose into the urine. That must not be confused with the diabetes, which requires the actual diagnosis from the blood. So the routine use of urine tests for the confirmation of diabetes in pregnancy is not recommended. Pathogenesis, the type 1 as we talked about, that is mostly the autoimmunity which is involved in the genetically predisposed individuals with the environmental effects. What is meant by that? The environmental effects mean just as we call as nature and nurture, both are very important. The autoimmunity is a fundamental immune abnormality in type 1 diabetes, is a failure of cell tolerance in the T cells. This failure may be a result of some combination of defective clonal deletion of self-reactive T cell in the thymus. You all remember that as the child is born, as the neonate comes into this world, there are certain autoreactive clones which are progressively destroyed or deleted from our immune system, so they may not destroy our own system. So if there is a defective clonal deletion, this is one of the proposed mechanisms. These self-reactive T cells may destroy the beta cells in the islets of Langerhans, as well as defects in the function of regulatory T cells or resistance of the effector T cells to the suppression by regulatory cells. So these different mechanisms, they may lead to the development of diabetes. Genetic, more than 30 different susceptibility loci for the type 1 diabetes mellitus are now known. Of these, the most important is the gene cluster on the chromosome 6 short 21 and contributing to some 50% cases of type 1 diabetes mellitus. There are others non-HLA genes and the insulin gene which may be involved in case of that. Environmental influences, viruses by directly causing damage or molecular mimicry may be there. The induction of the immune response, by inducing the immune response, these viruses they may be indirectly causing the development of type 1 mellitus. Evidence of autoimmunity that comes from the circulating islet cell antibodies, insulin antibodies. So if you are asked to write down the pathogenesis of type 1, you must write the different things which I have told you, that is the presence of the autoreactive clones of T cells, the disturbance in the effector T cells, and the disturbance in the regulatory T cells, along with this evidence of the autoimmunity, that is the presence of circulating islet cell antibodies, insulin antibodies, and the antibodies against glutamic acid decarboxylase, and plus the inflammatory infiltrate which is present in the pancreatic islets, and especially recurrence of insulitis and selective destruction of insulin-secreting cells in pancreatic grafts. This is an experimental evidence which lets us know about the autoimmune basis of type 1 diabetes mellitus. This is how normally the case is, that progressively it doesn't present suddenly. Progressively, with the loss of the beta cell mass, usually with the developing age, it may present, say, there's in the beginning the glucose intolerance, and progressively that would lead to the development of the diabetes mellitus. So normally I told you that this normally present in between this age group 10 to 20 years. It may present even at an earlier age if there is a more rapid destruction of the beta cell. The histological features, well, this is just a photomograph show you. You can see here this is a islet of Langerhans which has been infiltrated by the mononuclear infiltrate or lymphocytes and cells, etc. And the pathogenesis of type 2 diabetes mellitus, this is more complicated because a number of genetic factors are involved. And what is the evidence? The high concordance rate among the homozygotic twins, which is almost 70 to 80%. The environmental effects, greater than 80% of the individuals, they are obese people. So obesity has got somewhat a direct relationship with the development of type 2 diabetes mellitus. The metabolic defects, so insulin resistance and beta cell dysfunction, we have already talked a little about that, what is meant by insulin resistance, that the peripheral tissue, especially the muscles and the fat adipose tissue, they become resistant to the effect of this. And beta cell dysfunction means that the beta cells, they don't respond in the manner they should, that the initial, say, rapid manner of insulin secretion may not be there. There may be a disturbance in the protracted phase which follows the initial phase. And the pathogenesis of type 2 diabetes mellitus, the two metabolic defects that underlie type 2 diabetes mellitus are insulin resistance, that is the failure to inhibit glucose synthesis in the liver, failure of glucose uptake and glycogen synthesis in the skeletal muscles, and failure to inhibit lipoprotein lipase in adipose tissue. From here you can see that insulin failure to inhibit the glucose synthesis, so there would be increased synthesis of the liver from the process of gluconeogenesis. There would be failure of the glucose uptake and glycogen synthesis in the skeletal muscle. So this would lead to increase in the level of the glucose in the blood, and failure to inhibit lipoprotein lipase would lead to increased restriction of the proteins, as we saw. If you now recall that what is the effect of insulin upon the adipose tissue, you would see that these are the different things which lead to in fact decrease in both muscle mass and the body fat, which is characteristic of the type 2 diabetes mellitus. Beta cell function, that is manifested as inadequate insulin secretion in face of insulin resistance and hyperglycemia. What is meant by that? Say a 70 kilogram individual, he or she requires 50 units of insulin per day, but the insulin which is being secreted is not adequate for that. As we acquire more and more weight, that level of insulin that almost becomes insufficient, and progressively The increase in weight can put on more stress upon the beta cells, and that can lead to the exhaustion and ultimate burning out of these beta cells. The obesity and insulin resistance, the risk of diabetes mellitus increases with increasing in the body mass index. The central obesity is more uh, important in this case as compared to the peripheral obesity. Central obesity, you may have seen individuals who have got a pear-shaped body, that is their abdomen is protuberant, they have got uh, uh, the more as compared to their arms and legs. On the other hand, peripheral obesity, that is in an individual in whom almost whole of the body is obese. So the central obesity is more important in this case. This is the increased level of the free fatty acids and increased level of the intracellular triglycerides, which lead to inhibition of insulin signaling. So these two processes, they are responsible for that. You must remember, excretion and inflammation would lead to excessive glucose in the beta cells, and macrophages cause the release of the inflammatory uh, uh, substances, for example, the interleukin 1 beta. Beta cell dysfunction, high levels of insulin for respective levels of glucose. We have talked about that qualitative, it may be qualitative beta cell or maybe quantitative. What is meant by qualitative? That is the loss of normal pulsatile pattern of insulin secretion and attenuation of the rapid first phase. And quantitative, from this we mean that there is a decrease in the beta cell mass, and that beta cell mass, I have told you, may be because of a number of factors, the actual destruction because of the inflammation and progressive burnt out of these beta cells in the face of increasing body mass. Islet cell degeneration and deposition of amylin, a substance which get deposited around the beta cell and can lead to progressive ischemia and decrease in the function of. This is a diagram taken from your book. This is how the obesity can affect. You can see here in the individuals, the adipocytes, they release the adipokines, the free fatty acids, inflammation is there. This leads to the insulin resistance, and the pancreatic beta cells, when as they are normally functioning, say in a 70 kilogram individual, if he or she keeps on putting weight, the beta cell, they try to compensate for that by increasing the output, by increasing their size, but progressively the proposed mechanism is that these beta cells, they get exhausted, there is a failure of the beta cells, and this is how the diabetes mellitus type 2 is going to. Further, you can see here the adipose tissue is a dynamic tissue which is associated with the release of number of hormones, the leptins, which lead to insulin sensitization. In fact, they also enhance the satiety as well. The free fatty acid, the resistance, they have got a negative effect upon, and there is increased insulin resistance. On the other hand, adiponectin, that is associated with the insulin sensitization. So an abnormality in the say the cells, the beta cells and the fat, especially the coordination of it, that leads to the development of diabetes mellitus type 2 diabetes. Here is a diagram again, if you can say obesity, lifestyle factors, genetic. So in a genetically predisposed individual, the insulin resistance, which leads to compensatory beta cell hyperplasia, which keeps the glucose in the normal level, progressive or early beta cell failure, impaired glucose tolerance, and ultimately late beta cell failure will lead to overt diabetes mellitus. Four major metabolic abnormalities: obesity, impaired insulin action, insulin secretory dysfunction, and increased endogenous glucose output. This is very important to be remembered, that what are the characteristic features of type 2 diabetes mellitus. Those are the obesity, impaired insulin action, insulin secretory dysfunction, and increased endogenous glucose output. These are the four pathogenetic mechanisms which lead to the development of type 2 diabetes. Clinical presentation, most of these patients, they are normally over the 40 years of age. Polydipsia, polyuria, they are the important features. Ketonuria, this is not a significant clinical presentation in type 2 diabetic. It is more important in the type 1 diabetic. In their marked deficiency of insulin is there. In the females, candidal vaginitis in the woman may be an initial manifestation. In many patients, they may have no symptoms. The plasma glucose, when it exceeds 126 milligram per deciliter or higher after an overnight fast or more than one occasion after 75 gram oral glucose test, gives a diagnostic value R 200 milligrams per deciliter or more after 2 hours after the glucose intake. This is in fact the basis of the OGTD or the oral glucose tolerance test. And how is it performed? Normally a patient is set to ask a carbohydrate rich diet for 2 or 3 days, and then after an overnight fast he is brought to the lab. There he is given about 75 gram of glucose oral load, and then a value of about glucose after say 2 hours is taken, and if it is more than 200 milligram per deciliter, we label the patient as diabetic. Hypertension, dyslipidemia, and atherosclerosis are often associated with this. Oral glucose tolerance test I have already discussed how is it done, and the impaired glucose tolerance, we have said that if the values after oral glucose tolerance tests are between 140, more than 140 but less than 200, we say that these patients have got impaired glucose tolerance and they are at risk of developing the diabetes in the coming time. Glycated hemoglobin, this is very important. Hemoglobin becomes glycated by ketoamine reaction between the glucose and other sugars and the free amino groups on the beta chains. Only the glycation of the N-terminal valine of the beta chain that imparts sufficient negative charge to the hemoglobin molecule to allow separation by charge dependent techniques. These charge separated hemoglobins are collectively referred to as hemoglobin A1, and among them hemoglobin A1C is the one which we take and with the value of which, if it is more than 6.5, we say and that the patient is most likely diabetic. And this is nowadays one of the most important parameter which is there to monitor the progress of the diabetes mellitus. This is a table to show you the differences between the type 1 and type 2. Here you can see the onset of type 1 diabetes mellitus is at an age of less than 20 years, while the type 2 usually present at age more than 30 years. Normal, the patient of type 1, they may be normal weight, while the type 2, they are usually the obese people. There is a markedly decreased level of the insulin in type 1, while the insulin level may be high, or in the earlier level it may be moderately low, or maybe low at a later stage. No islet cell antibodies, non-ketotic hyperosmolar coma is common, while ketoacidosis is more common in type 1 diabetics. 30 to 70% concordance in twins, which again is in favor of the autoimmunity. 50 to 90% concordance, which means that there is most likely the genetics which is involved in that. Autoimmune destruction of beta cell is there, while and absolute, which can lead to absolute insulin deficiency, while insulin resistance, skeletal muscle in the adipose tissues and the liver, and beta cell dysfunction is the characteristic feature of the type 2 diabetes mellitus. The insulitis in the early marked atrophy and fibrosis and beta cell depletion is there, but no features of insulitis may be there in case of the type 2 diabetes mellitus in the pancreas, in the beta islets of Langerhans or the beta cells. The focal atrophy and amyloid deposition is there of the beta cells in case of type 2 diabetes mellitus.